Hi, everyone. A huge welcome to our global audience online. My name is Sarah Bendalia, and I'm the Director of International Engagement at Transparency International UK. We're very pleased to have you here with us to hear more about one of our key arguments, why corruption should be considered a public health emergency. COVID has set us back and has unfortunately halted progress towards universal health coverage, with many people still facing enormous barriers to accessing quality health services. COVID-19 has also further exposed corruption vulnerabilities and weakened already fragile health systems. For far too long, tackling corruption has not been given the focus it rightly deserves. It's viewed as a problem too big to solve or reduced to an othering phenomenon, where responsibility for tackling it sits beyond the remit of health sector professionals. Very rarely has it been looked on as a fundamental component to systems performance and resilience within the health sector. Transparency International's Global Health Program is very pleased to co-host this critical conversation with USAID, where we will hear perspectives from government, multilateral institutions, and civil society on why corruption in health matters and how we can tackle it. Our global health work at Transparency International focuses on building efficient, accountable, and transparent health systems. A key aim is to reduce money lost to corruption in the health sector and ensure these resources are directed at improving health outcomes. We know that just from a handful of Western countries, almost $600 billion annually is lost to corruption in health, twice as much that's needed to close the gap on ensuring universal health coverage. We also know that in low-income countries, over 80% of people have experienced corruption in the health sector, which further pushes them into poverty and drastically and adversely affects health outcomes. We work towards and encourage others to embed accountability, anti-corruption, and transparency approaches into all health systems policy and reform efforts, because without doing so, universal health coverage and ultimately health for all, as well as interlinked sustainable development goals, cannot be sustainably achieved. We are pleased that USAID recognizes the importance of tackling corruption across sectors and within systems. Corruption was seen by the global community as a technical challenge, but it's now recognized as a systems issue affecting everything that USAID does. The recently published Global Health Anti-Corruption Integration Handbook from USAID is a prominent example of efforts to fight corruption in the health sector. I'd like to introduce Rebecca Turner, who is Health Development Officer, Senior Advisor for the Global Health Bureau, working in the Office of Population and Reproductive Health. As a health and development professional over the last decade, she has been focusing on public health supply chain and health system security and risk management. Through these efforts, she has managed USAID's supply chain security contract and helped the Bureau for Global Health work towards the agency's anti-corruption commitments. Rebecca will introduce the panelists and moderate this session. Thank you.
Thank you so much, Sarah. Good afternoon and good evening. Thank you to everyone who was able to join. Before jumping in to introduce our esteemed panelists for today, I'd like to give you a brief overview of the objectives that we hope to cover with this session. So we want to look at understanding a little bit more about where key vulnerabilities lie within the health system and how corruption has been minimized at those key points identified. We're also going to have a dialogue that looks to explore around how transparency and accountability measures can be effectively built into health systems planning, budgeting, and procurement processes. And finally, we'd like to dive in a little bit more on what can be done to embed anti-corruption and integrate anti-corruption interventions into the core health systems approaches that we pursue both at the global and national levels. So with that, I'd like to introduce our panelists for today. We have with us, and please feel free to turn on your camera and as I introduce you. So today with us, we have David Clarke. David is a senior public health lawyer and a health policy and governance specialist. David works at the World Health Organization in Geneva as the acting unit lead for the Health Systems Governance Unit. Before he joined WHO, he was working as a senior official in the New Zealand Ministry of Health and as an advisor to global health and international development agencies in over 50 countries. At WHO, David is the global leader for the institutions and law theme at headquarters, and in this capacity, he leads on private sector engagement for universal health coverage, anti-corruption, accountability and transparency in health, and UHC law, and working with parliamentarians to achieve that universal health coverage. He's also the WHO representative on the steering group of the Alliance for Anti-Corruption in Health. Welcome, David. Next, we have Dr. Patty Garcia. She is a professor at the School of Public Health at Cayetano Heredia University in Lima, Peru. She's the former Minister of Health of Peru, Dean of the School of Public Health at UPCH, and former Chief of the Peruvian National Institute of Health. She's an advocate against corruption and has authored numerous articles on corruption in the health sector, including op-eds for The Lancet. Originally trained as a physician, she became the first Peruvian to be elected to the U.S. National Academy of Medicine in 2016. Welcome, Dr. Patty. Next, we have Sheila Massin with us today. Sheila is Executive Director of Transparency International Kenya. There in Kenya, she's worked extensively on addressing corruption within the health sector, supporting countries to improve the transparency of their procurement practices, and advocating with the national government for greater transparency around emergency procurement, just being two examples. Sheila has 19 years of work experience in anti-corruption, governance, program management, media, and outreach, having served as programs manager and head of programs over the last 5 years prior. And last but not least, we have Jonathan Cushing. And Jonathan is the program director of Transparency International's Global Health Program, which works to ensure effective, accountable, and transparent health systems, which leave no room for corruption. Jonathan's background is in health system strengthening, and prior to joining Transparency International, he spent over 10 years working on improving access to and the quality of care in South Asia and Sub-Saharan Africa. So without further ado, now that I've introduced our panelists, we'd like to jump into setting the scene and understanding a little bit more, having an exchange on where key vulnerabilities lie within the health systems that we're working. So I'd like to ask each panelist, starting with you, Dr. Patty, to describe concrete examples that you've seen and have sought to address from your experience. Over to you, Dr. Patty.
Thank you so much for the opportunity, and thank you so much for bringing the big C into discussion, this issue about corruption. So coming from a Latin American country, I live and work in Peru. I have lived my entire life really surrounded by corruption, which unfortunately was viewed as the status quo for many. When I trained as a medical student, I saw corruption related to providers, practices, supplies, drugs, and more. But because resources were scarce at that time, there was not too much to steal. However, when I became the Minister of Health in 2016, I realized the magnitude of the problem, especially because there were more resources. With more money, there is more corruption. Even the availability of foreign aid has fueled corruption, and not only in low-income countries or low-middle-income countries, but really everywhere. So I have seen that, unfortunately, in order to move implementation, for example, it has been viewed as acceptable and from the side of the funders to just ignore what is going on, which is obvious. Simple things like paying for healthcare providers to attend training sessions that should be part of their job, and it also should be considered an incentive. has been terrible as an example of corruption in our countries. I mean, if training is useful and is good quality, the right people should be the one that is trained. But unfortunately, because there was payment in between, that has not really been very helpful. When you ask me about examples, I mean, I was bringing this that had to do with funders. But as I said before, I mean, there are so many things that happen. Once I was visiting a hospital and I was told that the CT scan machine was not working. And actually, what was found is that there was a paper clip inside the machine. And that is what really make it damaged the machine. And it was used basically because the idea was not to have any services in the public sector, so people could be forced to go to the private CT scan that is located in like a block very close to the hospital. And the same thing happens with the laboratory equipment, which is broken, is not working, so people need to pay out of pocket, although that service should be for free within the hospital. We have seen also issues on the purchase of medications that are supposed to be given for free to the people that have national insurance. But the medications are denied at the public health center because supposedly the public health center doesn't have enough medications, although at the central level, we have bought enough of them. So basically, when I was Minister of Health, we started an investigation, Ministry of Health and the Minister of Interior Affairs. And actually, we found that there was a big scheme in which there were people at the storage of the pharmacy storage that was taking outside the medications to pharmacies that were part of a big network. It was like a black market. And there were people outside the hospital that they call it the poolers, that when the patient was told at the pharmacy within the hospital that there were no drugs and that they had to buy outside, these poolers, these people that were outside, were telling the patients that there were pharmacies where they could buy them at a good price. And actually, those were part of this black market. We started this investigation with the idea of trying to find not only how it works, but who was behind. But unfortunately, and that also happens, there were changes in the government. I left my position as Minister of Health, and the investigation was not followed. So we have seen problems at very different levels. And unfortunately, those should not be taken as, the problem is that they are taken as if that is the way we live in our countries. But those are causing a lot of damage to people. And we have even evidence that people sometimes don't even want to go to health services because that means for them a lot of money, and they are afraid of these out-of-pocket payments.
Thank you so much, Dr. Patty. I think you opened us off right there with theft, leakage, diversion, nepotism from external funding coming in and how that's utilized and attributed, absenteeism and unjust referrals for services that ought to be free. Thank you so much. And I'd like to see, David, over to you if you'd like to build on some examples of vulnerabilities that you've seen within the systems at the international, national, subnational levels. Thanks, David.
I think a lot of the problems that Patty was describing are actually governance problems. So and that's how we'd look at them. And these issues of how funding is allocated, how decisions are made in health systems are fundamentally problems, seem to me to be fundamentally problems of governance. And that's how we've been looking at them in WHO. I mean, at WHO, we're not an anti-corruption agency. We're not in the business of investigating, as Patty seemed to try to do, how these activities are happening. But what we're trying to do is to understand the systematic issues that are underneath these issues. So how come these pullers could be outside the hospital and be diverting patients? I mean, why weren't the patients receiving the services and the medicines they needed in the hospital? What was going on? So that's how we're approaching it. We're about to have a meeting in Geneva in 2 weeks' time of our anti-corruption network, and one of the things that we're going to do at that meeting is to look at a list of what some experts have suggested to us are the big anti-corruption issues that we should be trying to tackle. They've come up with a list of 5, and we're going to look at both those issues, and some of the things on the list will come as no surprise to you, things like corruption and procurement, etc. But we're also going to look not just at those issues, but we're also going to look at the feasibility of tackling those issues. We think there's an issue here about not just to try and better understand corruption, better understand the drivers of corruption, but also trying to understand what we can feasibly do, where we should prioritize our efforts. I think that was definitely a lesson during the pandemic. There was all this extra resources going into health systems, and there could have been a range of things that could have been done to try and address the risks of corruption in those circumstances. But where should we have put our efforts? Where were the areas of biggest risk? And I don't think we talk enough about that. Over.
Thanks so much, David. Sheila, can I ask you to add where you've seen corruption present within the health systems in Kenya where you're working? You're still on mute.
Thank you. Yeah, thank you. I think now I'm able to be heard. Thank you very much, Rebecca, and the organizers of this webinar. For us in Kenya, maybe I can start by just commenting that for a long time, in the last 10 years, more than 10 years, we have seen high instances of corruption in the health sector, and which has really negatively impacted, the realization of the right to health, which is supposed to be one of the secured rights within our constitution. Corruption has really robbed our country of critical funds that is meant to really ensure that citizens are able to access quality health services. It is a public service, vaccines for children, essential drugs for the vulnerable and the marginalized, better health facilities, guaranteed healthcare personnel, because you still get to some facilities, especially in rural areas, where you'll not find a well-experienced medical personnel. Like in some facilities, you'll not find a medical doctor, or even where there's a doctor, maybe it's just very few doctors when you compare the ratio between the doctor to patients, such that then you find people having to queue very long lines. Sometimes you'll find that they don't have adequate health equipment and supplies. You find people having to queue to get certain services, for instance, particularly those seeking services for cancer, radiotherapy, chemotherapy, kidney treatment. You find inordinate long queues such that you may actually be told you have to wait for 6 or even 8 months, to get a particular service. And as a result of that, we've seen a number of Kenyans having to go abroad. It's actually cheaper to go to countries like India to get treatment, because here you'll not be able to, even if you can afford it, the queue is quite long. Supplies, you go to some hospitals, and you'll be told that, we don't have this particular drug that has been prescribed. Maybe if you go, 5 meters or 100 meters from here, you can find that in that private facility or a private pharmacy, which is actually owned by a medical personnel who is employed in the public health facility where you're being now referred to a private health facility. So I really associate with some of the comments, experiences that Dr. Garcia has made in regard to some of those difficulties in regard to health. I don't know that you want to talk about our experiences in regard to devolution now, Rebecca, or that comes later.
That comes later. Thank you so much,
Okay,
Sheila.
thank you.
We'll give Jonathan a chance to elaborate. We're not trying to depress our audience, but we want to paint a realistic picture of those vulnerabilities we're trying to
Okay.
address and then move on to what we can do about it. So thank you for sharing that, Sheila. Jonathan, over to you.
Thanks, Becky. And as others said, we see corruption across systems, and in our work, we've sadly kind of seen it play out from the kind of the research and development of medical technologies all the way through to the delivery of health services. One of the areas that CI has done a lot of work on is procurement, and the procurement of goods and services. Why procurement? Because globally around 1/3 of total government expenditure is outsourced effectively on procurement. It's critical. In the health sector, if you didn't procure things, systems wouldn't run. You need the equipment, you need the drugs, cleaning products, etc., etc. And we see it as a key point of vulnerability within health systems, particularly in health, because the sector is complex. You're procuring specialist equipment. It's not something that you can go down to a shop and buy. This is highly specialized goods. You need specialist knowledge in order to decide quite often what you're procuring, for instance, with drugs. It's not as simple as kind of comparing drug A and drug B. There's a lot of information that's considered there. And classically, in the health sector, there's this kind of imbalance of knowledge and power. You have highly skilled people, rightly so, who run the health sector, doctors who've got a high degree of training, but it makes it more difficult to question then, hold to account if those right decisions are being made. And to add to this, when contracts are made available, they're often quite heavily redacted. And we see this a lot with pharmaceutical contracts. There's a heavy degree of commercial confidentiality cited there, that contracts can't be brought out and published, and commercial confidentiality is cited. We've seen this a lot during COVID with vaccine contracts being heavily redacted, massive kind of redaction throughout those documents. But we've also seen it in our purchase of other medical goods as well. It's very difficult to know what's been signed up with. How does this play out in reality? I mean, numerous examples from around the world. In Honduras, we've seen kind of shell companies being registered in order to bid on medicines contracts. Shell companies are companies that essentially, as the name suggests, are empty companies, only really set up for the purpose of that contract. And collusion there, the Ministry of Health and others kind of circumvented tendering practices by using emergency contracting procedures, which meant that companies could compete behind closed doors, with the end result that the Honduras paid more than about 40% above the international average for medicines. Another example from Nigeria, we've seen the collusion in contracting to win awards for the construction of primary healthcare centres, where contracts, when later assessed, were found to be within about 1 naira of each other, suggesting that collusion had been going on. And when it actually came to it, only 1/3 of these health centres actually ever became operational. Issues with the contracting, the actual kind of the construction of the health centres meant that this money was wasted. COVID has been another massive example, and TI's analysis of the UK alone raised concerns about $4.5 billion worth of contracts that warranted further investigation. And I think the thing to remember here is, whilst I'm talking about the economic cost, this is not just an economic cost. This means that people can't get access to the care that they need. They have poor quality care because they can't access the medicine. So all of these examples, and corruption in procurement leads to poor health outcomes.
Thank you so much, Jonathan. So now for our audience, that you've gotten to hear some of the main key vulnerabilities that we're seeing across public health systems. We'd like to move to the next topic today to kind of focus on what can be done from a transparency and accountability perspective to addressing these vulnerabilities systems wide. So David, segueing from what Jonathan had mentioned and noting that WHO will consider procurement as one of their key focus areas, could you share with us some tangible ways that WHO is addressing corruption in the health sector?
I think the first thing to note is, in many situations, we don't actually know what works. I mean, I think that's acknowledged by many experts, and I know that there was a systematic review done in the Cochrane review about this. So one of the things that we're trying to do is to have a conversation about what does work. So we've been working with academic partners, for example, to try and better understand and scale up some interventions that do work. The other thing that we've been doing is looking at working with partners who can come at this issue from different entry points. So, I mean, we can come at it from a very technocratic point of view with looking at providing normative guidance about how to better improve accountability and transparency, which is something, of course, we will do. But we also want to, as part of our convening role, work with different agencies who can address this from a different angle. So this is why we have a global anti-corruption network, which is meeting in 2 weeks in Geneva. So this is the other thing that we're trying to do, is to try and bring together these different agencies with different perspectives and see what we can do collectively. Because often agencies work on this topic on their own, rather than looking at how different perspectives can be brought to bear, whether they be human rights perspectives, whether we, dealing with corruption at the human rights through human rights institutions, or whether it's a technical question where WHO might be bringing to bear its normative expertise, or whether it is an issue which requires intervention from civil society. So we actually that's what we're trying to do. One, we're trying to understand what works and what doesn't, because we don't think there is an evidence base at the moment. And two, we're trying to work with partners to better see if we can come up with these combination approaches, which we would hope might make a difference. And one of the big focuses of the meeting that we're having in 2 weeks' time is to have a discussion about what works and what doesn't, and where we should be putting our emphasis, and what might be the most feasible thing that we can do in the short term. Over.
Absolutely. And I know we have representatives that are going to be involved with you on that. And I think as we look to approach this from a collective and even multi-sectoral perspective, there's so much room for synergy on aligning on terms, aligning on what we mean by procurement as a process versus a function, and how we measure the success of our intervention. So really looking forward to what comes out of that. Thanks, David. Jonathan, you were mentioning a lot around procurement of health products, noting some of the schemes you've seen in contracting as a really high risk area for corruption. Could you talk us through some of the learnings that you have on addressing this? Thanks.
Thanks. Yeah, I think to summarize, to start, the key thing here is to open up the data, get the data out there. And the core principle behind this open contracting has been around for a while. Which is effectively very simple, that you put out all of that information on contracts, that it's published, and it's available for government, but also civil society businesses to use. This has been around for a while, and there have been some really positive examples of where it's worked, Ukraine and Chile, but two that kind of come to mind, where they've made significant savings in the health sector on their medicines procurement, and have seen efficiency gains. There is more to it, though, than just putting that data out there. You do need to go further than that. And it's about using that data. So once the data is out there, it needs to be used to understand where the kind of key vulnerabilities lie within the system. And to do that effectively, it's more than just contracting data. You need to have the overall picture there. So what I would like to see is many more kind of governments putting out planning information, so putting out the kind of the sectoral plans, the budgetary allocation information, budgetary information, in order that the whole picture can be seen, so that you can see, it's possible to see why that decision has been taken, why have 10 ambulances been procured, for instance. That contract can be done in the cleanest way possible to get those 10 ambulances, but it might mean that money's been diverted from something else. And use this information to build up accountability. Parallel to that, I think we need to build up interest in actually using that data. So that's working with a number of kind of different groups, working with health groups, health interest groups, community groups as well, to get them interested in using the data, understanding the data, using it to further health outcomes. Other groups such as journalists play a really vital role here as well, and they can hold power to account, hold government to account here. And I think the thing about this is also, it doesn't have to be high-tech, massive kind of data, cloud-based data solutions here. It can be done fairly simplistically, kind of putting out information in print form, publishing this at the local level, where community groups are interested, perhaps in a district health district health system can be done with local groups there through meetings and kind of classic approaches there. And there's a really big value in community accountability here, community monitoring as well. Work with communities to get them to ensure that they have access to information. Communities often have a really good understanding of what's going on, what their health needs are there. And if they're given the information, it's really powerful. They can work with district administrations to make big changes.
Fantastic. Thanks so much, Jonathan. Dr. Patty, I'm coming over to you, drawing on your experience as a former Minister of Health. We were curious, what advice would you provide to ministers of health and health practitioners to be able to tackle corruption within the health system? What are some tangible things that you see that can be done?
Okay, first of all, it's not an easy task, I have to tell you, okay? I have been Minister of Health but I'm an academician and I'm a researcher, and I have had this opportunity of jumping into the government and back. So there are many suggestions for strategies to confront corruption, okay? But as David was saying, the reality is that we don't have tangible evidence of what works and what doesn't. And that's something that I had to confront when I was Minister of Health. So myself, I was trying to look as a researcher or as an academician, okay, what are the things that work so I can implement them? And actually, we don't know yet, okay? And that means that there is a big gap there that somehow needs to be brought into the picture, and we need to invest on understanding what works, and also on understanding how can we measure corruption, because if we're gonna really try to measure impact, we need to know how to measure it, which is kind of difficult. Anyway, so as a minister, knowing that there was no hard evidence of what works or doesn't, I kind of started working on the things that could be done and could be helpful. So number one, and that's why I think that this document from USAID, this global health anti-corruption guide is quite interesting. Number one, it's important to assess where are the vulnerabilities in the sector or where you are working. So in Peru, for example, one of the big problems, it's a problem in different countries too, and it's a form of corruption, is absenteeism, for example. So one practical thing is that we need to have better ways of monitoring and supporting providers also to get to their work on time and to complete the shifts that they are supposed to. There could be controls and monitoring, but there can be also incentives to recognize those that are really doing what they are supposed to do in their job. Another thing that is a big issue in our countries are dual practice. So people that work in the public and in the private sector. There are lots of reasons why providers justify doing that. For example, that there is not enough payment in the public sector, which is something that we really, as people working in public health, we need to discuss. There should be a good payment, but dual practice is also an open window to practices that could become, that are corrupted. That in a way may limit to improve the quality of the services that are given, so the patients could be sent to the public sector to be seen. And those are two things. So identifying where could be problems and starting to create certain activities like monitoring, incentives, or it could be ways or things that ministers of health can do together with the rest of the team. Of course, people talk about access to information to the public or transparency. Well, let me tell you that in Peru, we have a transparency office in every single office of the Ministry of Health and in all health centers. And you can access all the information through the web. But the problem is that nobody takes a look at that. And so we need also, as Jonathan was saying, to create capacities within the health providers and also within the community. So take a look at the data and you can find things that are wrong and you can change them. I remember as a Minister of Health entering into the website and seeing that certain health centers were investing a lot of money on buying bread, supposedly bread, that had nothing to do with the job that they needed to do. And they didn't have enough money, for example, to buy pharmaceuticals or drugs that they needed or supplies. And so that was a hidden way of taking money from the budget, but it was there, it was transparent, but nobody was doing anything. So it's not only the transparency, but who does that monitoring, that surveillance, and that's what people talks about, the power of people. How can we involve the citizens into this? Another thing that I tried was the declaration of conflicts of interest of directors, generals, and all the people that was working with me. It was a big deal, but it was quite important because that is part of transparency, but you can make obvious also conflicts that could arise and you can take actions before anything happens. The other thing that is important is the incidence of institutional and social control, which means that everybody should know what corruption is, believe it or not, because we are living in a society in which there are lots of things happening. People consider sometimes that the petty things like paying to be managed in the clinic is not considered corruption. It's a need, which is wrong. So we need to change social values. Upper tenders and procurement of medications. In my case, for example, I went into the radio and said, like, we're going to open this procurement. I mean, that allowed us to really decrease the cost in 20%. And when I asked all the people that was participating in this tender how the prices were lower, they told me it's because they didn't need to pay bribes because everything was open. And finally, one thing that is quite important and needs to be done is there is a need to have systems for which people could feel secure of reporting possible cases of corruption, and we need to have systems for investigation and eventually, but for investigation that are efficient, and it has to be open and people has to trust it. So we started, for example, a system that was called With Health, You Cannot Play, okay, which means that, I mean, there shouldn't be corruption in health because it's very serious, right? And we were able to decrease the time for investigation of any type of reports related with corruption to 14 days. And actually, it was very helpful because we realized, started to identify where were the places where things were happening and how to try to control this. My final comment, okay, because you were talking about recommendations as a Minister of Health, one thing that is true is that these things cannot be done alone. And you have to prepare yourself because you will be attacked. Okay, so that's another thing. And I really think that we need to create a societal support for people that start confronting corruption.
That's so true. Thank you, Dr. Patty. There's so much to unpack about what you said there, and it has to be multi-pronged. It can't just be looking at, you know, societal norms and empowering civil society, and it can't just be working with law enforcement in a vacuum. And so we know that these multi-pronged approaches to create deterrence for bad actors is what has been proven effective. So I wanted to develop a little bit on what you had mentioned. Before you go, just wondering, when you talk about monitoring, would you consider a whistleblower approach? Did you have dedicated individuals or personnel that were working for you that could filter maybe like a hotline or a whistleblower approach? Or what did you mean by monitoring?
So we have two things, okay? We created this website, okay? So we use website, WhatsApp, a hotline for people to call and really report issues that were happening. That's how we realized, for example, that there were people were selling jobs within the health centers. I think because I was so open saying like I was not going to tolerate those kind of things. And I created different ways to have channels where whistleblowers will feel more comfortable. And we have also a team that was dedicated to investigate these kind of things. We were able eventually to receive in a very short period, because we did, I mean, in Peru, ministers of health last very short, okay? I tripled the average time of a minister of health, and I lasted only a year and 2 months. So in 6 months that we really developed this very carefully, we have more than 500 allegations, not reports. I mean, we have thousands of reports, but allegations that were really, really structured. And we were able to sanction more than 200 officials, 32 were fired, and we have like 34 accusations because of crimes against public administration. So we really were effective of identifying things, correcting things, and creating a system with different norms. Unfortunately, in order to have that, you need to have somebody who really wants to fight, because after I left, all the things had been weakened. So I think when I said monitoring, it's not only this part, but I wish there could be also civil society behind it. So even if to try to push this to continue, because it took a long time to put it into place, but it's so easy to just disintegrate.
Thank you so much. Thank you, Dr. Patty. Sheila, I want to come over to you, knowing that devolution has taken place in Kenya over the last decade, with local administrations that are now responsible for health, amongst other areas, decentralized budgets and procurement. What lessons can be drawn upon from this process that you've been involved in, and has devolving power strengthened accountability? And if not, what more needs to be done in this space? Thanks, Sheila. Over to you.
Yeah, thanks. Thank you, Rebecca. First of all, maybe let me just add that in Kenya, what I would think what is critical also to understand is that we have a very high prevalence of communicable and non-communicable diseases. We are also still very heavily dependent on donor supports towards the health sector. And for instance, up to 75% of the funds that are spent on the treatment and management of HIV, tuberculosis, and malaria programs come from donors. So it's also sad that we've had even embezzlement of money that has been given to us by donors other than what we as taxpayers are contributing. In regard to your question you have asked me, yes, we have a system of devolution since for the last 12 years now. So health is a shared function between the national and the county government. And the national government has retained previously was in charge of all health management of all health functions. But now the national government only manages the national health policy making process, and also the management and provision of health services at the national referral hospitals, which are just 5 in the country. So the county governments really have the bulk of the responsibility in health service provision at the county level. This includes, resource allocation, the development and management of health facilities, service provision, and also county level policy formulation and implementation. So as a result of the evolution in terms of what has worked, I think we've seen some little progress in regard to, there's some level of public participation with that system of devolution, because we're now seeing a little bit more, we're not there yet, we're not quite there yet, but there's an improvement of citizens, stakeholders who are involved in planning, in budgeting and oversight processes, and are able to, give their priorities in terms of health needs. So we've seen some progress there in the last few years. We've also seen some level of, increased resource allocation due to the budget autonomy of the counties. And we've seen also the health sector taking, like the highest percentage of budgetary allocation in most of the counties, and which are comprising almost, you'll see like in most county budgets, spending on health is comprising between 25% to 30% of the total budget. We're also seeing more support from development partners going directly to counties, and then they're thereby able to respond to the specific county needs, or because different counties have different health requirements. And so as a result of this, we've been able to see certain resources just dedicated to certain issues affecting particular geographic areas in the country. I think maybe the downside of this, what has really not worked, is that, the flow of funds from national to county governments is not quite there yet. The national government has maintained a high budget allocation at national level, really stifling resources that should go to the county governments. As much as we say that we're seeing more resources for county spending, but we're not quite there yet, because the national government is retaining a lot of the resources. And then we've seen a lot of unnecessary expenditure, by national government on the purchase of medical equipment, which is not prioritized by the county governments, but the national government has still decided to go ahead with some of this procurement of medical equipment, which is not prioritized. But we know why that is done, because there's normally a vested interest there. Like we had a scandal which was even investigated by which led to a parliamentary inquiry, where the national government paid for certain medical equipment, but those medical equipment are just lying in the counties and have not been used because there was no supporting infrastructure to enable the utilization of those equipment. Head medical personnel were not trained to use some of those medical equipment. So in some places you have X-ray machines and other very, very high-end machines, which people are not able to use because they have no resources or no human resources or infrastructure to be able to apply them. But we're still paying for them, with our taxes in regard to, because they have been leased from elsewhere, but we're still paying for them, but have not been used. Then I think another issue we've seen really, and which speaks to the example I've just shared, is really lack of proper coordination between the national and county governments. So you're seeing a lot of policy incoherence due to competing interests by the different levels. For instance, you've seen we have a national insurance, health insurance scheme, but then we've also seen some counties trying to develop and implement their own social health insurance schemes. But then again, this is sometimes quite political, because every time then you have a political transition, at the county level, some of these schemes have not really been sustained, but yet we've already spent money on it. I already spoken about the issue of corruption, because there's been sustained corruption in the health sector at both levels, the national level and also the county level. And COVID-19, the COVID-19 pandemic for us, especially at its height in 2020, really exposed the soft underbelly of corruption in the health sector, because it is there that we saw really what happens in regards to procurement in the health sector. We saw a lot of irregular procurement processes where companies were registered for the sole purpose of getting shadowy contracts, to supply COVID-19 PPEs. And some of these PPEs actually are still stuck in a warehouse somewhere owned by the Kenya Medical Supply Agency, because they were also really procured at a very, very inflated costs, and so our counties were not even able to afford them. So they lie somewhere and they've not really been used. So Kenyans have wasted resources because of that. Many of the corruption scandals, as I said, have really revolved around irregular, illegal procurement processes. There have been clear instances of conflict of interest, embezzlement of funds through irregular expenditure, and also price gouging. But there's also been a high level of impunity, because as much as we've had a number of corruption cases, many of those cases remain unresolved for several years. I can't remember even if we've had anyone being held to action or held to account, taken to court and successfully prosecuted and convicted for corruption in the health sector. So many of those who have perpetrated corruption in this sector are yet to be held accountable through successful prosecutions. And of course, the failure to prosecute these corruption perpetrators makes it possible, for others to continue daring and very bold, because they know that really nothing will be done. So there's a high level of impunity. And also as a result of corruption, we've seen that there have been high costs of health services, especially for chronic conditions. I think I explained that earlier. When you talk about treatment of cancer, treatment of kidney diseases, Kenyans are really overburdened. As much as we're still paying taxes, and you expect that people are then able to get services when they go to medical facilities, we still many times have to go in our pockets. Like this comment that's always made by Kenyan. If I open my WhatsApp right now, you find me, I'm almost in 10 groups of people asking for support to fundraise for health expenses, because they are not able to access them in public facilities, and so they prefer to maybe take them abroad. And even if they're able to access them here, it still costs quite a bit, and you still have to pay quite some money for it. So we have all these normally personal fundraising initiatives, and so Kenyans are encumbered by all these very high medical costs for relatives and friends and so on. I think I had explained earlier what then happens, and many people are opting to go abroad because it is much cheaper to get the services abroad.
Thank you so much. You have learned a lot through this experience, and I think highlighted some of the trade-offs with devolution, and in terms of exposing further irregularity and incoherence, but then also suffering the HR shortage, and and having to continue to train and monitor even more personnel that are involved, and perhaps needing even more. So now, thank you so much. Let's jump around, and we want to be able to get to audience questions. So thank you to everyone who's been submitting those questions. We wanted to just spend a few minutes on what more can be done to really embed these anti-corruption approaches and core health systems approaches at global and national levels. So Jonathan, can I come to you to speak a little bit about what you feel needs to be done to get ministries of health and perhaps across governments more broadly to embed anti-corruption into their systems approaches?
Sure, and I think colleagues on the panel have kind of alluded to some of the approaches. I think two kind of key things from my side. One is that we've got to get rid of this normative idea that corruption is part of the everyday way of doing business. It's not, and we've got, but unless we really address that, we're not going to get anywhere on the subject. We've got to kind of work and recognize that corruption has a real detrimental impact on health outcomes. In order to do that, we need to understand what's happening within systems. And I think, and as anti-corruption advocates, we're often guilty of this as well. We talk too generally quite often about this. I mean, we use a statistic, 7% of global health expenditure is kind of lost to corruption. That works on one level, but when it comes to a Ministry of Health or a Ministry of Finance, you've got to have precision information there. You need to have much better intelligence on where the corruption vulnerabilities and corruption is taking place in systems, where these actual losses are, in order that you can actually go and present a business case to the Ministry of Finance or the Ministry of Health to say, okay, this is where we need to invest money, because there is a case to be made to doing this in terms of cost savings, health outcomes. If you don't do that, we're not going to get the priority and the funds allocated to tackling corruption. I think it's really important as well to recognize that corruption isn't a checklist approach. You can't just take a checklist, port it from one context, put it into another. You've got to know the systems, got to know the drivers of corruption as well. And I think colleagues earlier mentioned the kind of cases of corruption at the point of service delivery, so where patients have been diverted, as Patty said, with the X-ray. It's important to understand what actually drives that there as well. Are there bottlenecks within the system? Are there legal loopholes that mean that healthcare workers are exploiting it? Are they being paid, et cetera, et cetera? So better information throughout the system. And only then, once we've got this information, understand where those vulnerabilities are and within the system, can we start to develop the kind of contextualized approaches that will actually work to enable systems to be more resilient to corruption. Yeah, thanks.
Thanks so much, Jonathan. David, I wanted to come to you with the same question, if you want to opine on that, and really how we would prioritize the interventions and which we would pursue internationally versus national and subnational in more devolved systems. Thanks.
I think I think I'd agree with Jonathan that we really need to unpack what we're talking about when it comes to corruption. When I've been listening to some of the speakers, some people might not describe some of the things that were being described as corruption or corrupt activities, but they would regard them as weaknesses in the health system. So what we're doing in WHO is, instead of talking about corruption per se, is that we're trying to think and unpack in each health system area, for want of a better term, the health system building blocks, how system weaknesses may impact on things like absenteeism, weaknesses in procurement systems, etc., etc., or even look at things like how health systems are being funded either by donors or by ministries of health, to see to identify areas where there are weaknesses because of fragmentation in systems. So it's not always just simply a matter of labeling something as corruption. I think there's work to be done to better understand the underlying drivers that are causing these problems in health systems, because they might not, and that if you do it that way, I think it's easier to deal with. If we look at it from the point of view of health systems, a health system strengthening approach, I think it's far more palatable for governments to be able to address these issues. I think the other thing that we probably need to do is to do more work to quantify the losses that the governments are suffering. I think that would also help significantly. Over.
Thanks so much, David. So now we come to our audience Q&A. Thank you to everyone who submitted a question. I'd like to start now with a question for both Sheila and Dr. Patty. Would you say that corruption in the health sector is an important theme in your country's political debate at this time? And can you comment on what civil society organizations can do to strengthen the topic in the debate and obtain political commitments and action? Thanks.
Thank you so much. Unfortunately, I don't think that, at least in Peru or in Latin America, corruption in health in general, okay, is being seen as a problem. And that's a big issue, and that's a problem itself. So we identify corruption as a problem in general, okay, but we are not seeing as an issue that needs to be tackled, okay, and so that's why I really think that what some of the other panelists have said is quite important. We really need to define what corruption is, okay? I agree with David that it's important to understand the drivers within the health systems, but for me, there is a word of caution there, okay? Because several times that's the way of justifying things that are happening. But we can see health centers, providers that are not corrupted at all and work within the same health system that is dysfunctional and fragmented. So there is something else that is going on there, and we need to understand what's going on there. I think we really need to do a better job in order to have a case investment, as Jonathan was saying. We need to really be able to measure, so to define well all these situations that have to do with corruption, measure them, and then try to put a number of how much we are losing on them. And because we work in the health sector, I think that we need that, I mean, the numbers and the money to convince the ministers of financing to give the money to act on these things. But I think we need also to involve the health workers, because, and this is quite important, you were talking about how not to make this too negative. So please, the first thing is that not everybody is corrupt, okay? That's not, I mean, there are corrupt, there are corruptors, okay? But there is a lot of other people that are not involved there. There are some that are scared of the corruption, okay? But there are other people that are very honest and they are tired of corruption and they are upset and they are trying to do something. So we need to involve them, really. And they are from the health sector and are from the community. So for me, I think we need to really push for messages that corruption is not tolerable, that corruption is inequity, that corruption is inefficiency, okay? And for each of them, we need to have numbers, okay? And we need to see corruption as a disease of health systems. And if we think about diseases, we need to screen for them, and that's the assessment of vulnerabilities. We need to find ways of preventing, okay, like with diseases. So we need kind of like vaccines, right? Or prevention actions. And then we need to have ways of treating them. And I really think that funding agencies have also a role, okay, especially in our countries in these issues. Like, and I think that just feeling uncomfortable of talking about it is not anymore the way of going. And communities should have a role, and we need to empower them, okay, to be part of the solution and to be part of those voices. And, you know, there was a question there that I read, and they were saying if the reports of corruption should be anonymous or not. That's the same question that I asked myself and my team was asking when we were going to start this reporting system. And actually, we allowed people to report things anonymously because still you need to build trust, okay? But giving us enough information for us to do all the investigation that was needed. And that gave people more security because also, as I said, there are people that are not corrupt, but they are scared, okay? And we need to give them some security. So whistleblowers that are anonymous, but then can give you enough information for an investigation. I mean, it worked for us when we implemented.
Thank you so much, Dr. Patty. Sheila, do you want to share some of your thoughts on this as it relates to being part of your country's political debate and the role of civil society?
Yes, thank you. And I'll just try to address some of the other questions because they're related. But the first question from Francois in terms of whether corruption is a priority with our government, with the political class, no, it isn't. Not corruption in the health sector. I wouldn't say that's a priority, even for the previous regime, because even during the heightened political campaigns this year, because we had an election about 4 months ago, so we have a new government, but there was very little mention or commitment to address health corruption. The time when we saw pressure to address corruption was during the COVID-19 corruption cases, which to date, no one has been held accountable. I think the investigations have been going on for now more than 2.5 years. No one has been taken to court. And the fact that these several cases remain unresolved, even where cases where donors have stopped some of their funded programs or asked the government to reimburse funds that have been misappropriated into corruption, but no single person has been held accountable. I think the government has simply gone to its accounts, to the exchequer, withdrawn money and refunded some of the donors who have demanded their money back, but not held people accountable. That tells you that there's a high level of impunity and there's really very little political will to fight corruption. In terms of what civil society organizations can do to strengthen this issue, and maybe I'll say what we have done as civil society. I think we have pushed for, I mentioned earlier, the issue around participatory budgeting. It's not quite there yet. I think there's a question from Kate on that, but it's not there yet. But where at least we're pushing for citizens to be involved at the budgetary processes, planning processes, and then going ahead to be involved in the implementation of health projects and also in the social audit processes as well. So they're well informed on how much money is disbursed and how it's used. We're also pushing for open procurement platforms. Deployment and use of open systems, using the open contracting standards to enable, enabling disclosure of data and documents at all stages of the contracting processes. We have advocated for the development and use of price indices for pharmaceutical commodities to safeguard against inflation of prices for common commodities in being used in the medical facilities. We did that even during the COVID-19 procurement processes. we are pushing for public transparency, beneficial ownership, and access to information on who owns companies that are trading with the government, to safeguard against conflict of interest in the award of government contracts. Because I mentioned this is a big issue in regard to health procurement, and also access to information to the public. In fact, as TI Kenya, we have adopted the use of ICT platforms, like one we call the Action for Transparency mobile application, where we put in information on health budgets and expenditure to enable citizens to be able to monitor expenditure, budgeting, and then report, when they suspect cases of corruption. So I link this even with that question around whistleblowing. It's just really important, just providing citizens with platforms through which they can report. I think for many of the Transparency International chapters, a number of us have what we call the advocacy and legal advice centers, where people can report cases of corruption. In Kenya, we have that as well. We have mobile platforms, and even they can visit physically to report cases. Some of the cases we receive are on health corruption. So if establishing effective complaints and complement systems is also quite key. And lastly, I think the issue of social accountability, if we really want to involve citizens, is very key. So adopting an approach of social accountability, in fact, it is something that we tell our development partners to embed, that every time they're giving government money, there are certain things, obligations they must make of them, of our governments. Ask them to ensure that there's public participation in all the processes involving the use of their money and also use of taxpayers' money, and also ensuring that Kenyans, our citizens, are involved in terms of the social audit processes, have systems like, integrity pacts, impact assessments, community dialogue sessions, to ensure that money is used in the right way and citizens are part of every decision-making and implementation processes in regard to the health sector.
Fantastic, Sheila. So much to unpack with what you just said. I think beneficial ownership is an area that's really underemphasized in the health sector. It's where we've seen the energy sector make great strides, and I think there's a lot of cross-sectoral collaboration that we could bring to the health sector there. And then when you talk about social audit, social accountability, I think one of the challenges is how to marry that with like an internal ally or actionable evidence that's within the institution that can marry it with internal controls and actually affect the change. So it's interesting though, I've heard social audit, but I didn't hear anyone reference like a supreme audit institution or a third party. So I didn't know, Sheila, I know you turned off your camera, but have you seen engagement from a supreme audit institution or third party when it comes to auditing in your country context, or was it just through like the social auditing?
Yeah, no, we have the Office of the Auditor General, which routinely and every year does conduct audits at both national government and county level, and even for all government entities. So every year it will have reports on the Ministry of Health and also county governments in regard to even expenditure in the health process. The weakness we have there is that, yes, we get these audit reports from the Auditor General, but then what it gives in its reports are recommendations. So in the case where, for instance, money cannot be accounted for, it will give recommendations. Now, these reports go to Parliament, but then Parliament many times does not act on the recommendations that are given to by the Auditor General. So you'll find that a lot of recommendations or actions that the Office of the Auditor General makes are at the end of it not acted upon. So you continue to see this same county governments or the ministries still receiving money, but still every year, year in, year out, not accounting for money. So there's even been a proposal that for every government entity that has not been able to account fully for the monies received or has been adversely mentioned in the audit report, they should actually be cleared fast before they receive any new any channeling of funds from the government. So I think that's a good proposal, but it's still a proposal. It's yet to be done. I think the other point I also want to make which is very positive, that has come from our Office of the Auditor General, is that they have adopted what they call the Citizen Audit Accountability Framework, where they're now engaging citizens in the audit process. So it's not just the auditors, from that office going to the ground and doing their own assessments, but also engaging citizens to also get to the point where they're able to scrutinize, what's the impact of some of these projects? Was there value for money? Because sometimes you have all this health, you may have some health projects, but then they're really of very little use or make sense to citizens. That was not a priority for them, or maybe there were issues that the citizens could have noted, but then you as an auditor, because you're just coming in to audit at a particular period in time, you may not notice. So I think that is quite positive in terms of now kind of embedding a social accountability approach, even to the audit process being conducted by the Auditor General.
Absolutely, and tying it to the institutions. Thank you so much for elaborating on that. I want to come over to you, Jonathan. Talk a little bit about the private sector. Are there some lessons to be learned here? And can those positive private sector healthcare experiences be transferred over to the public sector?
Yes, sure, thanks. I think there are lessons that can be learned there. I think it's important to recognize the kind of the fundamental difference between the kind of two sectors, and the private sector by and large kind of is operating on a for-profit basis, and that perhaps drives a kind of higher degree of interest in ensuring that there is kind of, well, less loss through the system, because there's somebody there who wants to ensure they make a profit at the end of the day. And that's always slightly different in government systems, because there is not that vested interest there to ensure that you make a profit on it there. That said, I think there are lessons that can be taken from it, and one of the, I think perhaps one of the underutilized tools that's actually been very popular amongst donors recently is the kind of the performance-based financing, the results-based financing model. So looking at how do you incentivize individuals within the system. I mean, it's classically been used more to kind of drive performance around certain health outcomes, but can that type of approach be used within healthcare delivery systems to incentivize those at all levels within the system, so those within the procurement department, etc., to actually kind of look and ensure the systems are delivering and there aren't losses taking place. I think the other kind of key bit, and healthcare providers are a big kind of, there's a huge degree of kind of difference amongst them, but one of the, looking at insurance companies, one of the things that they're very good at, again, they have interests here in not having losses, is intelligence-based use of data to ensure that their patients are getting the right services. Some may argue that they do it to kind of ensure they make the most profit possible. That's the debate for another day. But using data there, looking big data, but also assessing cases to say, is the right treatment being given here? Are we actually getting the health outcomes we're looking for? Monitoring for fraud as well within systems, false claims, etc., exist in some systems where they're insurance-based systems. So look more at kind of, how can we use that big data? And it's, as I said earlier, it goes beyond procurement data. It's about linking up these different data sets here. And I think kind of looking forward over the next kind of 5 to 10 years, we're starting to see kind of big data coming on the horizon, and there will be more use of that. And there's real potential there. Start marrying up. We've got wealth of information within DHIS systems, district health information systems within governments, and human resources information systems. Bring this information together, start using this to start understanding your patterns of healthcare delivery and how all of this links to improving health outcomes. That's the first step there. And then start using it to look at where it's going wrong, basically. And it may not be just corruption, but start to use that to improve systems. I think those would be my kind of top 2 kind of takeaways there from private sector.
Thanks so much. Yeah, there's huge opportunity for AI, and even on the procurement side, just picking up double invoice numbers, just saving you manpower in the revision of all the procurement documents. So yeah, thanks so much. David, I wanted to come back to you. We had one from the audience citing that, several low-income countries have laws saying that whistleblowers actually must identify themselves. Yet, could an anonymous whistleblowing also help identify possible systemic problems that we could, aggregate and then work on from the systemic level? So really, could you just comment a bit on the pros and cons of maybe the health sector developing its own whistleblowing system versus using the national system, perhaps run by an anti-corruption office or through the Prime Minister's office? And how would you ensure the protection?
It's quite tricky. I mean, I was in the New Zealand Ministry of Health in the 1990s when we brought in whistleblower legislation. And at that stage, it was anonymous. And it actually didn't work that well. I mean, even in a sophisticated system, a relatively sophisticated system in the country, which is usually rated quite highly on the Corruption Perception Index, the problem often is that even where it's anonymous, it's quite easy to work out who people are when you're involved in these situations, particularly in the health system and particularly in smaller communities. So I think more work needs to be done to look at the effectiveness of whistleblowing. I know it's often used as an example, but I think that we probably need to do some more research into what works and what doesn't, and whether having an anonymous whistleblowing system as opposed to a system where the whistleblower is actually named works or not. And then the whole question of whether or not you need a separate system for the health sector. Again, I think that's a very interesting question, but I'm not convinced that you do. I guess it depends who you're blowing the whistle to. You mentioned blowing the whistle to anti-corruption agencies, but some of the health systems I've been involved in, the whistleblowers schemes might be to an ombudsman or to the general. So I think we probably need to do a lot more work to unpack how these, maybe do a study to see how well these systems are actually working, and what lessons we can learn and apply to other countries. Over.
Thanks so much, David. And I'm sure, you know, if it wasn't within the national system, but to protect the anonymity, there would be a way to still aggregate and genericize to paint a picture of like the types of reports that are coming in. So
yeah, absolutely. Yeah, absolutely.
Okay, Dr. Patty, you mentioned announcing the openness of certain services should be free, but when people then encounter the opposite because of corruption, doesn't it undermine the credibility of the authorities' messaging?
Absolutely, that could be a problem. But one of the things that could be done, and I learned this from Chile, for example, is not only announcing that it should be open, but also, for example, what they did in Chile is they had these huge boards over the health centers that said that the services should be free. And they clarified what were the things that people should expect. And if this was not happening, to call this reporting number, right, and explain that that was happening. So I think it is important not only to say that it's open, but also to have ways in which people can complain if that doesn't happen. Unfortunately, and we have to make those systems simple, and that's what I think. But I completely agree with David that what we need to do is we need to study what works better. But making it, for example, anonymous can give people can make people feel more secure, and they may call, and we need to have simple ways for people to complain when they know that something should work one way and it doesn't. The first thing that we need to do is we need to assure people what are the kind of things that they should expect. And if they are not like that, they should be able to complain. So I think those two things need to go together. And of course, once they complain, we need to have a system that should go and find out what's wrong, what is not working, and try to fix it. So in other words, we need to have definitely a systemic view, and we need to assure that we need to construct that trust to people. In Chile, they have been doing that, and that's what I started trying to do here in some of the health centers. But as I said, there is a need to have some funding, sustainability, and we need to work on education. I mean, unfortunately, and not only the public, but also the health providers. Health providers need to understand that when they work in the public sector, they are being paid for that, and they are doing a service. It's not, so they are doing a service, but they are doing their job also, okay? And people have to know that those services exist because they are paying taxes and because that's their right. So we need to empower we need to empower people. And that's part of, I mean, I think we need to work on education too, of course. And people need to know that corruption should not be the standard, okay? The standard is to have better services and no corruption in general.
Yeah, thank you so much. And yeah, it's tying health rights to health literacy and working, thank you so much. So I think we only have time for one or two more questions. Sheila, I wanted to come over to you with this one. We know bribery at the point of service delivery can push people further into poverty. Have you learned anything through devolution and what you've seen on how this could be tackled?
Mm-hmm. Yeah, I would say that yes, bribery in Kenya is affects a number of sectors, and the health hasn't been left behind. We in Transparency International Kenya, we normally do our regular bribery index, where we measure the patterns of bribery in different services and sectors offered by the government. And the last time we did one published in 2020, we found that the prevalence of bribery in the health sector was among, actually, I mean, the health sector is one of the most bribery-prone sectors. You found that, in fact, the prevalence of bribery in the health sector was at 17%, and 18% of those people seeking services in the health sector were most likely to be asked for a bribe. And in fact, the average share of the average payment paid as a bribe was $20 US. This in a country where most people live on below $1 a day, just emphasizing the rate of poverty in this country. But I would say how we can best tackle this, because bribery has been known to limit access and is a huge obstacle to service delivery. I think for us, the best practice has been, the establishment of effective complaints and complement systems, to allow whistleblowing that will be able to expose corruption happening in the health facilities, but also emphasizing, and I think I've seen a question around that, on safe whistleblowing mechanisms. But this reporting tools, the whistleblowing systems must be safe, to allow for anonymous reporting, and also joint review of complaints in teams with citizens, which have citizens and also user representation. I think I've said that one of the things that we have currently in place in Kenya is we have health facility management committees, or where citizens are able to sit in health boards running some of these facilities, such that there's a level of public participation even in the management of these health facilities. And I think this is important because then citizens are able to be part of the solution and are part of really the process in making decisions and addressing some of the concerns that are there in health services. I think the other thing that we must see to be able to tackle bribery in the health sector is just enhance awareness to citizens on their rights and responsibilities. Because many times when we've asked Kenyans, why did you pay a bribe? And many of them don't report. Actually, only 13% of Kenyans will report cases of bribery. And when you ask them why you didn't report it, because they say, well, I didn't know how to report it. I didn't know what system to use to report it. But some just say that I didn't think that anything would be done to address that particular corruption that I faced. But I think it's important to really enhance awareness among citizens on their rights and responsibilities. Specific for the health sector, I think the use of service charters, where you get into a health facility and you're able to see that this particular service will take this amount of time, it will cost this amount of money, so that it's very clear that you shouldn't have to pay any additional fees, to get through that particular queue or to get that service. So we've been advocating for that, and also having outreach days where health facilities go out to the communities and just sensitize Kenyans on, the services and so on, so that they're well informed. So by the time they're being asked for a bribe, they're able to say no because they know what or how getting that service. They know the process that is entailed. Thank you.
Thank you so much. So here we have our last question, and I want to invite all of our panelists, if you want to opine on this question, just ending on a point of safeguarding. So what prevents corrupt officials and political leaders from extracting public resources from the health sector? What safeguards can be put into place? Leave us with a hopeful message. What can we do to safeguard our resources? Thanks. Jonathan, do you want to go first?
Yeah, and I never thought I'd do this, but I'm going to draw on what my dad said. I think one of the things, kind of his philosophy on public sector corruption was it doesn't take place, and that's not always true, because public sector officials are frightened of losing their pensions, and I think we need to put in place some of the kind of there's a big cultural thing here about it being acceptable as well. In institutions, you walk into an institution. Is it culturally acceptable to do things? I'm very fortunate to work in an institution where a corruption, obviously, in Transparency International is not acceptable, but we have a certain organizational ethos. This is the way we behave, and that's really important. I think you need to balance that with then the kind of the carrot and the stick, if you like. So the kind of the threats of, for instance, if you are corrupt, if you're caught being corrupt, you will lose a pension, lose those benefits, is also potentially powerful. I think it goes wider than the health sector, though, and it really kind of comes down to the kind of societal norms as well, around corruption as well. That's got to be embedded. It's got to be, you've got to build up that societal expectation that public services are there for the public. This is taxpayers' money at the end of the day, being misused. It's my taxpayers' money in the UK where I pay taxes, etc., etc. This is a public resource. This is theft, and it's not socially acceptable.
Thanks so much. I think we have time for one more panelist. Did you want to answer? Dr. Patty?
Yeah. Yes, I was trying to answer that question too, okay? And I found that there are some theories that experts are using, and there is one that has to do with the way people process rule breaking, okay? And actually, what we need to do is we need to work on decreasing the perceived benefit of an act of corruption in general in our societies, right? The psychological costs, the social costs, and the cost of doing a corrupt act. Shayla was saying several times that one of the problems that we have is that we have high impunity. So we really need to change that, okay? It cannot be acceptable, and it cannot be acceptable from the societal point of view, from my inside, okay? So psychological, as I was saying, and there had to be some penalties regarding that. So we need to work on that framework because it is really important for people. And I have seen this in other, I mean, in high-income countries, okay? People may not be doing something because they fear of what kind of penalty they will receive or how they will be seen, okay? So I think we need to work on this in this whole structure. It's difficult to say, but it's important. So we need to change on understanding the way people process rule breaking, and we have to make it more difficult. Okay, so impunity is one of the things that is quite important. Of course, let's work also on prevention, vulnerabilities, etc. But the context is important.
Thank you so much, Dr. Patty. And thank you to all of our panelists. Unfortunately, we're at time, and I'm sorry to those of you we didn't get to your questions. But I'd like to just briefly wrap us up saying that, you know, health systems involve a complex, multi-layered landscape of actors, each with potential drivers and forms of corruption. So hearing from our speakers today on some of the major categories of health sector corruption that span from central level, ministries of health, central offices, and regulatory bodies, to administrative functions such as health sector procurement, logistics, and hiring, and extending all the way down to the service delivery, interaction, and relationship between patient and provider. We really have established the pervasive risk and hearkening impact that corruption has on health outcomes and the emergency that comes as a result. So we hope that today, in hearing from our panelists a bit more about what can be done to detect and address these corrupt practices within the health system, that you leave this event with greater awareness of the vulnerabilities, but also hopeful about realistic gains and progress to be made to better safeguard our finite resources in health systems so that they work to the vulnerable and the sick who need them. Thank you so much. With this, we'll close our webinar. Wishing you all a great rest of the day. Thank you so much, David, Jonathan, Sheila, Patty, and Sarah.